Hello, everybody, and welcome back to another episode of Hybrid Healing Hour. Today, we are going to be talking with Dr. Mike Hafran, and the conversation is one and done medicine, gene editing, cholesterol, and the future of prevention. Hi, Mike. How are you doing?
Doing well, thank you.
Thank you so much for coming on. I am very excited about this topic, and I'm sure there's people out there already like, well, what does this mean? So first, I want you to kind of tell our audience a little bit about yourself and how you got to where you are today, and we are going to dive right in.
Absolutely. Thank you for the opportunity. Again, my name is Mike Hafran. I am a physician, originally trained in family medicine in New York City, and I have about 20 years of clinical experience. And in regards to my current job and position, I am in clinical research, so it's slightly different from clinical practice. And I'm what's called a principal investigator. So we are involved in helping companies not necessarily develop, but test medications that are coming out to impact the future patients, future medical conditions, and actually old conditions with new approaches. So that's kind of what clinical research is in a nutshell. And that's where I'm involved, making sure that these drugs are both safe as well as efficacious.
And we actually did a podcast with Dr. Baum before. So for our audience out there, go back and listen about clinical trials. And we talked about the ins and outs of how a clinical trial works, what they all trial. It's not always medications, like you said. It could be devices. It could be scans or screenings.
Why you should participate.
Yep, and why you should participate, risks versus benefits. So
Absolutely.
We've done that, and it was phenomenal. And so I would definitely recommend people to go back and listen to that one.
So what we're talking about today almost sounds like science fiction, right? It sounds like we are now so many light years ahead of where we were with medications in the past. Patients are always coming to us and say, well, I don't want to take a medicine forever. I just want to take something once and get it over with. And now it sounds like we're close to that frontier.
You are absolutely correct. And maybe this does sound like science fiction, but it's science fiction. I think that's coming close to becoming reality, and not just reality, but hopefully it's the common reality for many people in many chronic diseases.
So why don't we talk about it? What the disease that we're treating is familial hypercholesterolemia. Let's talk about that first. What is that?
Okay, great. And actually, familial hypercholesteremia, it is a mouthful. Let's just reduce it to FH. And that's commonly how we refer to it with that acronym in the medical, space. But what it is essentially a condition, a disease, unfortunately, it is inherited where an individual has the inability to reduce their cholesterol level. And this is due to a genetic defect or dysfunction in the liver cells.
And when you say cholesterol, we're mainly talking about LDL cholesterol.
Correct. There are many types of cholesterol. Some of them are good, but the bad ones are particularly bad, and LDL is one of them. And it is bad, not in and of itself per se, but what it does. Unfortunately, individuals who do have high cholesterol, cholesterol functions kind of almost like rust in a pipe. So over time, as you get more rust buildup in a pipe, it reduces the blood flow. And because of that, it results in some negative outcomes, particularly heart attacks and strokes. And kind of going back to the individuals with FH, because they cannot control their cholesterol or get it down, even with medications, they are at much higher risk for these events to happen.
When should someone think maybe I have FH versus just having high cholesterol? Is there a threshold?
Yes and no. So FH is, now we're much more aware of what it is. So it is a genetically inherited disease. So unfortunately, if you have one individual or a parent or a grandparent with that disease or with that diagnosis, there is a high likelihood of that being passed on. But I want to shift just a little bit and say that, there's another condition, and that is premature coronary artery disease that affects probably a lot more people. And incidentally, just to kind of clarify this, FH affects about 1 in every 250 people. But premature coronary artery disease affects a lot more people. And let me just define that. That means that an individual is more prone to having a heart attack at a much earlier age. So that's 55 for males and 65 for females. But essentially, it's the same. I'll use a bigger term here, pathophysiology. And that is there is an excessive buildup of cholesterol within those pipes. And the outcome, unfortunately, is the same.
Would you compare the premature coronary artery disease to the same as somebody who just develops hypercholesterolemia later in life? Or are these people, they've also had high cholesterol their entire life?
Now that's a little bit trickier. A lot of times, yes, they have had just higher cholesterol. But essentially sometimes we don't exactly know, to be totally honest, we don't exactly know what the mechanisms are, and it is multifactorial. Mm-hmm. It can be, not taking your medications, and it just happens because life happens. It can be some other genetic predispositions that we don't have the science to yet totally know. And then finally, it can also just be because of lifestyle exposures. Like maybe you unfortunately were in an environment where high fat foods, that was just the norm.
Right. Like the Midwest, probably. That's where I'm from, so I can say
cheeseburgers.
That. Yes, fried foods, everything's fried.
Even though we have great medications, not everybody responds to medications, right? I'm even surprised that we have a few patients who don't even respond to Repatha, one of the PCSK9 inhibitors, which is like a powerful drug.
No, that's an excellent point. And I think there are two challenges with medications. The first big group that I think everyone is familiar with are statins. So statins are there. They are a daily medication. They are designed to help reduce how much cholesterol the liver is producing. But they are a daily medication. A medication is only effective if you take it. The other thing is sometimes medications do have side effects. And these are, they're well documented. No one likes side effects. And sometimes the side effects are so severe that an individual has to stop those statins. The other medication that you mentioned was the PCSK9 medications. So those are slightly different. They're not pills. They are injections. And depending on which one you're prescribed, the cadence is a little different. Could be once a week, once every 2 weeks, once a month, that sort of thing. They do appear to be very effective. But once again, side effects can have a serious impact, and most of those are injections. I don't know of many patients that really enjoy getting an injection. So it's a challenge with that one as well.
Well, and only actually a small percentage of FH patients can reach their goal even with these medications, correct?
That is absolutely correct. Unfortunately, the stats are kind of dismal. About 3% reach their cholesterol goals if they have FH and they're employing all of these medications. It's kind of even slightly worse for individuals that have premature coronary artery disease. Despite a combination of medications or other things, maybe about 20% of individuals, 20 to 30% of individuals will reach their cholesterol goals.
So let's talk about this gene editing. So, people, I heard about CRISPR when I was reading the, I just forgot his name, the Life Force book with guy with Marfan's. I'm totally blanking on his name. But anyway, so the Life Force, Tony Robbins, that's it.
Of course.
That book was all about how to live a longer, happier life, I guess, full of quality, right? And they mentioned CRISPR in there, and I thought that was amazing because they were talking specifically about doing that for the ApoE gene to prevent Alzheimer's. And I would definitely be interested in that if I could find that study or learn more about it. But it's kind of nerve-wracking to think that this is something you go in, you cut out this, like for the ApoE gene, right? They were saying like if you are a 4-4 or a 3-4, you could cut out one of those 4s and replace it with a 3 and make you have somewhat of a lower risk, which they're doing studies to see if it actually does reduce your risk of Alzheimer's. But, I thought that was really cool, but it's still like, well, would that change anything else about me? Like it's changing your genes, right? So can you please talk about the difference between gene editing versus CRISPR and like what we're talking about today?
Absolutely. So again, this is where science fiction is becoming reality, and there have been some successes thus far. Most notably with sickle cell disease. I think has been proven. So it's not as if we're totally going into unexplored territory. We definitely are moving in the right direction. But to your question, I think gene editing right now, and let's start with CRISPR actually. CRISPR is very interesting in that it is, I'm going to call it, it's like microscopic scissors. I think you mentioned this, that it is a device or mechanism that goes in and actually snips out sections of your genome. Maybe we should talk about what
the genome
the genome
let's talk about
right?
that.
Exactly. So I think the best way to explain this is that your DNA is like an instruction manual for your body. And it's a language, just like a computer programming language, that sort of thing, except the language in our body is very simple. It only uses 4 sorts of coding mechanisms: A, T, G, and C. That's it. So, these are incredibly long strings, millions of letters long, and they're duplicated, all these other things. But what the gene editing does is, as we mentioned with CRISPR, it goes in with microscopic scissors and it will snip out a section or two, a very directed and pointing section. Right now, there are other technologies that exist as well. And the one we're talking about, and hopefully I can give more insight into, is another mechanism. I call it a microscopic pencil. What that does is it goes in with the eraser and erases just one letter. And then it rewrites the erased letter with the correct letter. So in a nutshell, that's kind of what gene editing is. And I know you brought up some concerns. I think hopefully we can go into those a little bit later, or we can jump into those now.
We can jump into it now. Let's do it.
Go.
Okay. So with gene editing, there are some definite risks. And I want to just kind of go through those with y'all. I did bring a note, so I just want to make sure I cover everything. The biggest concern, I think, for everyone, including the developers, the scientists, the PhDs that have studied this, is off-target editing. So that's a theoretical, and I will say this, it is a theoretical risk. And it worries a lot of people, as you just mentioned, with gene editing. And the challenge is, one would be concerned about, is the mechanism going in to the right cell and editing the right target? There really is only one target. That's the goal. Just edit that target, make the changes, and then the cellular machinery continues on doing its job. It can't
with replication.
Yes.
I mean, that's
It once the editing is done, you hope one hopes it's the right target, and then the machinery continues on. It doesn't know that, and there is a certain level of permanence. There's definite permanence because you're changing the genetic code. You're changing the code at a base pair level. Mm-hmm. So I think that's another big concern. And it's kind of a bit of a paradox because it's permanence. So there's both a benefit as well as a consideration. The benefit, theoretically, with gene editing studies is that no more daily pills, no more cadence of a once a week or once a month shot. This changes your genetic machinery. It changes all of your protein building processes. So that change should be permanent. But we do have to balance that with this concern over was the right target reached. And I can just say that, that there has been a lot of time, a lot of money, and a lot of research done with gene editing. A lot of, models have been, animal models, that sort of thing, have been explored. And the targeting seems to be quite spot on. And again, the goal is to get the right target and then have that permanence of therapy.
That's great. I mean, yeah, I love that you were able to touch on that. I mean, so I guess with Verve 102, with this specific trial, the goal is to replace the gene that is causing FH, which is causing this very high cholesterol and increased risk of early onset heart disease, right?
Absolutely.
And so I guess why not target or is it targeting like the PCSK9, or is that really what it's targeting then?
Yes. So actually, we should maybe go into a little bit of that detail.
Yes.
The how can I put this? So cholesterol is in everyone's body, but how does the body get rid of that? Well, the liver actually plays a big role, and I'm not sure everyone is aware of that. But
no, I would love for you to explain that.
Yeah, so
because I've heard your analogy with the recycled plant.
Yes, and the catcher's mitts. So, and I like to use the analogy of catcher's mitts because we have the little cholesterol particles going through our body, and there are catcher's mitts. And I like that because it's like catcher's mitts. You catch it, you're out. So that's typically what happens. Now, some people, again, based on genetics, sometimes they have a lot, sometimes they have a little of these catcher's mitts. Sometimes people, their catcher mitts don't work right. In some people, those catcher mitts kind of get recycled or broken down too quickly. And that is kind of what's going on or that is one component that is part of familial hypercholesteremia, or FH. So you had mentioned the PCSK9 inhibitors. So those medications work because what they do, the PCSK9 inhibitors are actually almost like a demolition team. So the PCSK9 actually breaks down and destroys those catcher's mitts. It's sad because it ends the baseball game early. I don't like that.
Right.
So there are fewer catcher mitts. Now, we all have all of these different enzymes and proteins in us. The unfortunate thing is that people with FH, their PCSK9 works over time.
And when we talk about this, I kind of want to make this where people out there can understand. So PCSK9 is what catches the LDL or
no, and this is where it gets
absorb the cholesterol.
This is where it gets complex because it's actually the catcher's mitts. Those are all throughout, but the PCSK9 is something in our body that breaks down and destroys the catcher mitts. You might be like,
I'm sorry, I meant to word that. The catcher's mitts is what's collecting the LDL, right?
Correct.
So because you think catcher's mitts are good, right? But when they're collecting all of this cholesterol, that's what's showing high in their blood work.
No.
Okay, so please let's I want to make sure
because I can that I've been told. PCSK9 is almost like a glue that makes the catcher's mitt hold on to the LDL, and the whole complex gets broken down.
Right.
Right. So
I want this to be explained for the audience.
PCSK9 inhibitors, which is what Repatha is, separates that so that the LDL can run free and the receptor is still available for another LDL to be grabbed.
Absolutely. So that's how the inhibitor is almost inverse logic here, because the inhibitor stops the demolition team that comes through and gets rid of those catcher mitts. You might be like, well, why does that have to happen? Well, like a mitt kind of gets old over time. It gets broken down, maybe some of the stitching breaks. So you got to get rid of them. So that's part of the natural process. And what this with Verve and their mechanism is that we're delivering a very specific, like I said, little microscopic pencil to go in and change one part of the genetic code that will allow the to kind of stop or reduce the total amount of PCSK around. So think of it as like the ultimate PCSK inhibitor. It just kind of like gets rid of that and allows more of those MITs to stay around, live longer, and function.
Now, from what I understand, there's many different mutations that cause FH. It's not one mutation.
Correct.
So is this targeting the most common mutation, or is this targeting multiple different types of mutations?
Yeah, now we're really getting into the weeds of genomics and stuff. And I can say this, that we are looking at both homozygous and heterozygous FH individuals to be enrolled in this study. Okay. And ultimately, this study is very interesting because also it is open to individuals that have a high risk. They have premature coronary artery disease, and they have been on multiple medications, maybe several statins at maxed out levels, as well as they have been taking or been exposed to some PCSK9 inhibitors, and still yet their cholesterol is not under control.
And we would say under control, you mean less than 70?
Yes, or actually sometimes depending on where we stratify the patient, it should even be lower. So, it's again, risk stratification based on multiple factors.
And how soon after the gene editing can someone expect to see the cholesterol numbers drop? Is it something that happens quickly, or is it something that happens over time?
Wow, you're asking some very tough questions here. It is definitely. I wish I could say yes, like within 24 hours. It's like as soon as you get your package from Amazon, you're like, I'm opening this up, I'm plugging this in, and that sort of thing. But it does take some time. Okay. But that's why when you're enrolled in this study, I think I do want to emphasize one thing, that this is a permanent change or a rewriting of your genetic code, at least just in the liver. I want to be clear about that. We're not rewriting anything else. Yeah. The target is the liver cell, as well as specifically the PCSK9 gene within that. So, that's the first thing I want to say. In terms of the efficacy, so this study really is looking at both safety as well as efficacy. And to answer your question, and this is, I apologize, a very long answer, but to answer your question, what animal models have shown relatively soon drops in cholesterol that were highly significant, and those continued on throughout the monitoring of the animal studies, so greater than 6 months. In terms of when do we start to see that, throughout this study, an individual will be experiencing a lot of blood work and monitoring, especially within the first few weeks to monitor for safety. The efficacy is anticipated to start to be seen within more like months. That's kind of, actually, I think that's pretty good myself.
Yeah. No, absolutely. And these are people that are so high risk that they've run out of options, right? There's not a lot of other options left for them. They've done the medicines and they still have events.
Absolutely. And the challenging thing is that not all medications work for everyone equally. Mm-hmm. And we have that additional challenge. It is really challenging to take a medicine daily for the rest of your life. And these can be very young individuals where they're going to have to start these medications in their 20s, 30s, and then all the way through the duration of their life. Yeah.
I think this is the youngest profile I've seen in the trials we've done with Flourish research, and starting at the age of 18, because FH starts even younger. So by 18 years old, they could be having heart disease, active heart disease.
Absolutely.
So I think this is really interesting. And, one thing we didn't talk about, Mike, was not only is it medications, but a lot of times people with FH, and which we did an FH podcast also with Dr. Baum in the past.
Oh, fantastic.
Yeah, specifically talking about this. So if you have any other questions about FH or this disease or the condition, go back and listen to that. But briefly, we've talked about them being on medication, for the rest of their life. And if they have to start 4 meds at the age of 18, they're on that for at least 50 years or more.
Absolutely.
Every day. But they also often do the apheresis. And
Lipid apheresis.
Lipid apheresis is something that people don't understand. It's very much like dialysis. It looks like dialysis, where you have to have blood taken out, and they have to do this, every 2 weeks, because their cholesterol builds right back up high again within that time frame. And so not only is it the pills and the shots, it's the venous punctures, it's just not an easy life. And that's isn't it like a 3-hour procedure?
Yeah.
I think it can take about 3 hours.
It truly is like dialysis.
Yeah. Right.
Absolutely.
So you have to sit there, every 2 weeks, there's 3 hours of your time. It's just, this is a life changing and life altering, I'd say, disease process. Can you please tell us also, you've talked about animal studies. Can you explain, this is actually a phase 1B trial. What does that mean? And also, is this actively open and started?
Okay, great question. So in terms of, there are different phases of clinical trials. And a phase 1, and let's just ignore the A, B, all of those parts. Phase 1 is a trial wherein we're really looking at 2 things: safety, as well as we're starting to measure the efficacy. This indicates that a drug or a device, whatever it is, has gone through many, many vectors of study, animal models, computer, what are those simulations, that sort of thing. And it has been tested in a variety of different sites, different universities, different companies. Well, I should not say different companies per se, because usually it's a proprietary thing. But it's gone through a lot of that testing. Now it has been proven that we can move forward and utilize this in the specific targeted population. So the main thing is to define or make sure that the product is safe, as well as start to measure some of that efficacy. As a study or investigational product matures through continued collected data, then it moves forward into phase 2, phase 3. And that really refers to how large of a population are we going to enroll. And usually it's very positively reinforcing. But all throughout any phase of any trial, the top concern is participant safety and making sure that there are no unexpected effects.
And with clinical trials, you guys have many eyes on these patients. I mean, these patients are better watched than anyone else who's seeing just their regular primary care doctor or cardiologist.
Absolutely. I think part of that comes from, and actually there's a particularly interesting study that points to that participants involved in clinical trials do have more positive outcomes because they are monitored twice as much. And by twice as much, everyone has their own physician teams, their own cardiologists, that sort of thing. We are another echelon that's overlaid over that. You do have visits with us. You have top PhD trained cardiologists watching over you. We're doing lab samples. We're doing MRIs and additional diagnostic testing. It's all part of the protocol, but it also involves you and a lot of extra, we'll just say, supervision or advisement.
So I want to know what actually happens if you could walk us through, say a patient enrolls into the study. How much of a workup is there prior to? When would they actually get this procedure done?
Sure.
Or infusion, I guess you should say. So yeah, tell us what would it be like?
Right. So every trial is a little different. So this does not apply to all trials. This is specific for the Verve trial. So initially, there is a screening period, and that's going to last up to 90 days. There's a lot of extensive testing just to make sure that you are a good candidate. And that includes blood work, ECGs, some diagnostic testing, liver MRI, that sort of thing. If we determine that you would qualify, then you would actually be admitted to the clinical research unit for the real treatment. And again, it's very extensive, and we make sure that you have a good understanding and that this is a good fit. A lot of times, these decisions really, it's a family decision, and we respect that, and it really should be a family decision as far as I'm concerned. But I think a lot of us feel that way. Mm-hmm. So once that initial period, which again can be up to 3 months, could sometimes be extended a little bit longer depending on how many tests we need to do, then you would be on site in our clinical unit to actually get the infusion. But before that actual infusion, we would do some final testing, and we usually pre-treat people with some steroids. This reduces any sort of potential risk, such as an IV reaction. This is actually very common practice, and it's standard of care even in hospitals and infusion clinics today. So nothing out of the ordinary there. Then you would actually get the infusion of the IP or experimental drug, and then you're closely monitored, again, in-house for about another day or two. We're doing those blood tests, we're taking additional ECGs, all of those things to make sure that you are safe and that we're not seeing any anomalous behavior or changes in the body. After that, you will be discharged, but still followed with a regular cadence of visits that are going to be a little intense at the start. Once a week, probably about once a week, where we continue to do additional testing, as well as now we're starting to be very curious about what's going to happen to your cholesterol. Over time, within the first year, the cadence of those visits will start to lengthen. So instead of coming in once a week for a month, then it'll be maybe once every 2 months, that sort of thing. And then it'll taper off near the end. Now, at that 1 year point, we actually have individuals transition into what's called the long-term analysis and observation. So that actually encompasses a total of 15 years.
Oh, wow.
So just to be clear, 15.
Yeah.
That's because we want to continue to surveil for any sort of unknown side effects, but also it really gives us great insight into how far or how low your cholesterol is going to go, your LDL, as well as how long is that preserved. The anticipation, again, because this is gene editing, we anticipate that the change should be permanent, which is, again, super exciting.
I mean, you said that there's been people out there who have been studied who are born without the PCSK9, right?
Absolutely.
So, and they're generally very healthy, very low cholesterol. So, like, are we just kind of hoping we're going to get them to be like, get
the individuals that kind of like have the high cholesterol to be like that?
Yes.
Absolutely. And this is what's super, if you think about it kind of in inverse, you're absolutely right. There actually are, just like we said, there are genetic mutations that kind of like increase your cholesterol. Believe it or not, there are some very lucky individuals that have a genetic mutation that have lowered their cholesterol. So there are definitely individuals out there who have volunteered to be studied and kind of enrolled in almost like the obverse of what we're doing, where they naturally already have a PCSK9 inhibitor in their bodies. So they've always had low cholesterol, and they live actually very long, healthy lives. And so that is exactly the goal. That's what we're hoping to achieve. Can we replicate that condition for the individuals that unfortunately inherited the other genetic mutation?
And this is not the first gene editing trial, right? This has been done before on other disease states.
Correct. Well, it's been very limited, at least in terms of like I'll use the term commercial success, but don't take that as a pejorative. I mean that it's, the funding has been there. It's impacted the right population. The safety profile is spot on. And then the efficacy, the effectiveness of the study has been spot on. And I think maybe we mentioned this earlier, the sickle cell disease. So, but this is, I really want to say, I think we are at an amazing and very exciting point in the science of medicine, possibly very much a pivotal point, because now we are using genetic altering or gene editing technology to address a chronic disease. I mean, not everyone has cholesterol challenges, but it is there and it does affect a lot of people, as we mentioned. But the hope is, if we can show that this works in one chronic disease, this can be translated to other chronic diseases. Maybe not all of them, but a fair number. I mean, there's already hope that we'll be able to address diabetes in a much more effective way, chronic kidney disease.
Right.
I think this is just the start. We're just at the verge of opening up a lot of possibilities for a lot of people.
I'm excited to follow this. I mean, at least for another 15 years, right?
Yeah, absolutely.
But let's be real. I want to know about the risks. What is the potential risks? Because that's what I think everybody out there is trying to wonder, because that's where my brain is. Like, I'm super excited about this, but yeah, I mean, obviously I'm assuming you have a risk of allergic reaction to the infusion site, right? Like almost like with any injection or IV, or shot even, you can get a rash at the site. But tell me more, like what are there any other risks that you guys have associated with this?
Yes. And, you're spot on. Even with an immunization or a shot you get at the physician's office, you always leave with a piece of paper that says, if you have these events going on, please give us a call. Right. So the top one is an infusion reaction. And that's just statistically present for, again, as I mentioned, even when you go to your physician's office or your rheumatologist's office to get an IV, the same things. So an infusion reaction, just so we're clear, is an individual may experience fever or chills or maybe some alteration in their blood pressure. They might feel lightheaded or even a fever. But as I had mentioned, when you're enrolled in this study, we do pre-treat someone or an individual with steroids. They're designed to help reduce the likelihood of that. So that's one big thing, and that's statistically probably the most common. Another thing that definitely has been seen in the animal models, is there are going to be some temporary liver effects. So by that, we do monitor closely your liver enzymes, and those do go up a bit in the first couple of days. And what does that mean? So that means that your liver is under some stress. But we have seen in all of the previous studies, as well as the animal models, simulations, that those do resolve or go back to normal within about a week.
Do they go up to more than 3 times the normal limit?
Oh, no, absolutely not.
So they're really not going up that much, just a slight elevation.
No, and you're bringing into context something we call Hy's Law, which is a very great concern in clinical research, and that is where liver enzymes go up to an unnecessarily or a critical high level that basically causes. What we do is we stop the study, stop everything involved.
Oh, okay.
So that's a dangerous scenario, and so far
none of that.
None of that.
All right.
Exactly. Another thing that I really do want to bring up is that we have seen a transient increase in the clotting mechanisms in animal models. So there is a potential risk of increased blood clotting, and that is why anyone that would be enrolled in this study, if they have any clotting issues, unfortunately, they cannot enroll. Okay. And again, this is our approach towards safety. So and that would come out in medical review, medical history. We did talk about the off-target editing as well as kind of like that double-edged sword of permanence. And this is
Meaning
very
if you don't hit the right target or the specific target.
correct. So yes, that's what the off-edit.
Then do you guys
Off-target
do
editing.
you go looking to see what target it hit, or is there a way to do that even?
I'm not exactly sure if there's totally a direct
right.
way to do it. Unfortunately, it would be more of an indirect way, and that's
And
why
monitoring blood
exactly
work.
a lot of monitoring,
Yeah.
a fair amount of blood work. So those would be kind of summarize up the greatest risks. But I do have to mention one more that I think is, we did touch on this, but I think it's very important to understand. It's terribly important to understand. And that is, unlike other clinical trials or medications, this is permanent. So, we can't stop. In other trials, I've definitely held the pill or like, oh, you know what, with an injection or an infusion, stop, like you're not getting a second one. This is one infusion and it is permanent. So that is something that people need to come into this with their eyes wide open. That is something that's very important to understand. And that's why I think this really is, it's not of course, everything is an individual's decision, but we certainly hope and we encourage that people have an open discussion with those members of their family and their friends who are important to them and help them come to the right decision for them.
And family should be involved anyway because it's genetic. And if
Right.
one member has FH, the rest of the family should be screened anyway.
Absolutely. And, I think I have seen this in terms of why people come in and volunteer for studies. Some people are just interested in being part of, advancing medicine. Some people come in because they're frustrated. They're like, I'm tired of taking this pill, or I'm tired of taking a pill that only does an okay job. And they want to help contribute to finding a better solution. But your point brings me to my last point, which is some people, we need to realize, especially with these genetic conditions and chronic conditions, there is a big gene component. And while we might not be able to impact people now, especially with genetics, we can have an impact in people's kids, grandkids, and future generations. And that's why this is so exciting. I think, to offer that, we can't totally change an individual's code, but if we can just make minute changes that are very targeted and can correct some of those, again, I don't want to use the word deficiency, but those errors, that's really powerful.
Yeah. And, I love how we've touched on that full circle, but when we come down to it and you have a patient who's possibly interested in doing a trial, this trial specifically, or any trial, what are some of the things you hear, like feedback from patients about considering a trial? Like, are there fears or frustrations or hopes, or, what do you hear?
Well, it's kind of been a very humbling experience for me personally as a principal investigator. I think for actually everyone on the staff, because we really get to know an individual and they get to know us. I've definitely had some participants in other trials. They're like, you guys are like my third family member. And we're like, oh, okay. So I think, that is very powerful. It's endearing and it's motivating. We do take care of participants as if they are our own patients, that sort of thing. I think in terms of some of those other motivations and things that people come in with, again, sometimes it's frustration that, our current technology and science isn't that great. It's not delivering on, what people would have hoped for. Some people along that frustration line, it's, there are no other options out there. I've maxed out the options we have. I think on the other end of the spectrum, some individuals are very motivated to just simply participate and push the envelope forward. Maybe because they had been touched personally or within their family by some sort of disease. And it is unfortunate that the disease processes are, especially some of the more complex ones, they're really devastating. And, anything we can do to help advance progress towards mitigating that or minimizing that is very potent.
And what is what excites you the most about this trial personally?
Okay, so I'm going to build out a little context here. I have been in practice for about 20 years. The world of medicine has completely changed just in 20 years. I remember when someone would come in for replacing, getting a knee replacement, that used to be 10 to 14 days in the hospital. Now, it's almost like it's really a day procedure. You come in the morning, you're walking out by late afternoon or the next day.
Yeah.
So similarly with this study in particular, so I think you can tell I've always been excited by change, positive change, pushing boundaries in a safe way. This again is so revolutionary because we are looking at really kind of defeating chronic conditions. Defeating chronic conditions in a way that really does not rely or put so much burden on an individual to remember to take their medicines or to come in, to get your blood literally changed out, through whether it's dialysis, that sort of thing. If we can be successful here, the opportunities to address other devastating chronic diseases is really within reach. Diabetes, kidney disease, all sorts of things. And that's what really excites me.
Me too. The gateway is what I feel, right?
The floodgates are going to open. And other than infectious disease, I don't think at this point, we've really come up with many cures for any chronic illnesses, right? And we're just about to get to that point.
Exactly. And you're absolutely right. I mean, what are our approaches now? It's almost like Band-Aids. And I hate to say that. I don't want to minimize all of the progress that's been done. But this is really revolutionary. Like we don't have to worry about these Band-Aids because eventually what happens? The Band-Aid peels off. Now, of course, your wound or your scratch is recovered, but with a chronic disease, it never recovers.
Right.
So that's why this is really exciting, and especially this Verve study. We're really hoping that it's going to be so impactful for so many people, and hopefully over time, as the success is shown, the safety is shown, the efficacy is shown, this is going to move from a phase 1 study to a phase 2 study where it will be open to more people and, the restrictions, because I have to admit there are a lot of restrictions on what sort of individual can enroll. And, that is something that we will definitely discuss with you to make sure that if you are interested, you would be a good fit for the study.
Right. That's in your guys' preliminary workup, right?
Absolutely.
In the interview, right?
Absolutely.
So speaking of that, if somebody is out there listening to this and they think that this trial applies to them, what should their first step be?
Well, I think their first step should be to talk to their physician, their cardiologist, their family members, their friends. That's truly, to me, that would be the first step. But after that, I think the next step would be to call Flourish Research. We are in Boca Raton, and there is one individual who is taking questions and kind of helping an individual through the start of this journey. And her name is Joanna, and I can give you her number if you would like. So it is 561-756-8206.
Perfect.
And then Joanna will get you in contact with me or one of the other cardiologists, and we would start that process. And even if it's simply to ask a question,
right?
Like, hey, or give me more information.
Exactly.
Or what is this about? Joanna is the person to talk to.
The go-to.
Exactly.
Great. And I'll also post her information and your information in the show notes.
Absolutely. And I will say this, anyone is always welcome to visit the clinic. And so that's 7900 Glades Road here in Boca, 4th floor.
Great. It's a beautiful facility.
It
I
is.
will
Thank
say.
you.
Yes.
Yes. We're really proud of it.
Yes. Well, thank you so much for
This has
coming
been
on.
great.
It
and
is.
really eye-opening.
Thank you. Thank you. It's been a wonderful experience. Thanks so much for giving me the opportunity to talk it. And thanks for promoting, continued growth and evolution in medicine.